Hi everyone, it's Dr. Cambo, and today we're going to explore the 2019 ICD-10 PCS Guidelines. These guidelines are the official guidelines that have been approved by the four cooperating parties, which are the American Hospital Association, the American Health Information Management Association, the Centers for Medicare and Medicaid Services, and the National Center for Healthcare Statistics. These guidelines are essentially a set of rules that have been developed to accompany and complement the official conventions and instructions that are provided within our ICD-10 PCS manual. These guidelines have been developed to assist both the healthcare provider and the coder in identifying the procedures that are being reported. It's so important to note that consistent and complete documentation cannot be overemphasized. The guidelines themselves consist of four main areas, and we're going to begin with the first area, which is known as our conventions. First convention, A1, reminds us that all ICD-10 PCS codes are comprised of 7 characters. Each character is an axis of the classification that specifies information about the procedure that is being performed. These characters are going to vary from section to section. So what that means, in different sections, they have different meanings. Guideline A2 speaks to the fact that one of 34 possible values can be assigned to each axis of the classification in a 7-character code. You see that again? All ICD-10 PCS codes must be 7 characters. Now, I mentioned that there were 34 potential values. Of note, those values are the numbers 0 and 9, or 0 through 9, and all of the letters of the alphabet with the exception of the letter I and O. I and O are not used because they can easily be confused with the numbers 1 and 0. Guideline A3, the valid values for an axis of a classification can be added as necessary. So those 4 cooperating parties, the Coordination and Maintenance Committee, they will make a decision as to when a new character value must be added. Guideline A4. As with the words in their context, the meaning of any single value is a combination of its axis of the classification and any preceding value. So, for example, the 4th character of the body part is related to the 2nd character of the system. Great example is body part value 0, central nervous system, specifies the brain, and the body part value 0 in the peripheral nervous system specifies the cervical plexus. A5, as the system is expanded, and it is expanded yearly, as it is expanded to become more increasingly detailed, over time, more values will depend on the preceding values for their meanings. All right, guidelines A6 and 7. First up, A6. relates to the index. The goal, the purpose of the index is for us to locate the appropriate table. It is the information in the table that we use to build our PCS code. According to guidelines, it is not required that we consult the index to build our code. So that's guideline A7. Because actually, a code can be built directly from the tables. Now, I will tell you, when you are brand new at using the ICD-10 PCS manual, you're going to find that you must begin with the index because you don't know which table you should actually be going to. So if you're brand new to ICD-10 PCS, I recommend using the index. Guideline A8. All 7 characters must be specified for a code to be a valid code. If 1 character is incorrect, your code is incorrect. So that means you must review the documentation thoroughly, and if necessary, you're going to query the physician for additional information. Now, one note, we don't query the physician for each and every little thing that we think is not complete. I recommend that you review the AHIMA article on achieving complete and accurate ICD-10 PCS queries. Next up, guideline A9. Within a PCS table, valid codes include all combination of choices in characters 4 through 7 contained in the same row of a table. So I think this is pretty tricky, and I think we should look at an example. So I want you to notice here, we have shoulder region, right and left, this first row here. And then we have shoulder region, right and left, in this second row here. Let's review the guideline. Within a given table, codes are built from the same row. That means if you're going to be in this upper row here, selection of characters 4 through 7 must be in this row here. If you're going to be in this row here, codes must be built within this same row. So now you're probably thinking, well, what's the difference between these 2 rows? Well, so they both say shoulder region, right? Then you have your approach character. But notice when you get to character number 6, there's a drainage device. So the million-dollar question is, did your patient have a drainage device? If no, you're not going to build your code from this row. You're going to build your code from this row here. All right. Next up, guideline A10 is related to the word and. And, when used in a code description, means and or, except when used to describe a combination of multiple body parts for which separate values exist for each body part value. Guideline A11, and this guideline is very, very, very important. Very, very, very important. Terms used to construct a PCS code are defined within the system. Let's say that again. Terms used to construct an ICD-10 PCS code is defined within the system. I think that's important to to note because sometimes the terminology that's used in the medical record may be confusing. The physician does not have to use exact PCS terms. The coder has to know the guidelines and determines the documentation that equates to the PCS definition. For example, when the physician documents partial resection, the coder can independently correlate that partial resection is excision. Now, I know you may be thinking, well, he said resection. That is true. However, according to ICD-10 PCS Guidelines, resection is when the doctor takes out all of a body part. So if the doctor says part of a body part, we code it to excision as opposed to resection. All right, guys, that was all of our general coding guidelines, conventions. Now we're going to go into our medical and surgical guidelines. As you know, the medical and surgical section is the largest portion of ICD-10 PCS. All right, so let's begin. First up, we're going to start with our body system guidelines. B2 is our body system guidelines. So B2 1A speaks to general anatomical regions. We're going to use general anatomical regions, body systems, only when the procedure is performed on an anatomical region rather than a specific body part. Now, on the rare occasion when there is no information available to support assignment of a specific code, we can also use general anatomical regions as well. Guideline B2 1B speaks to the division of general body part values as upper and lower body parts. Upper is going to be above the diaphragm. Lower is going to be below the diaphragm. All right, we're going to go on to our root operation guidelines. Remember, there are 31 root operations in the medical and surgical section, and it is critical that you learn the definitions of all 31 root operations. All right, we're going to start with guideline B3 1A. In order to determine the appropriate root operation, the full definition of the root operation as defined by the ICD-10 PCS system must be applied. So let me just say this again. It is critical that you learn your root operations. Guidelines B3 1B. Okay, couple of things here. Number one, the components of a procedure specified in the root operation definition and explanation are not coded separately. You're probably thinking, what does that mean? I'm glad you asked. This simply means that procedural steps to reach the operative site and close the operative site, including any anastomosis of a tubular body part, are not coded separately. So for example, let's say the patient has to have a joint replacement surgery because their knee joint, for example, is all messed up. So taking out the patient's joints to then put in a synthetic joint is not coded separately. Why? Steps to reach and close the operative site are not coded separately. Components of a procedure are not coded separately. And it makes sense. In order to put in the prosthetic knee, you got to take out the patient's own, knee joints. All right, we're going to go on to guideline B3.2, which focuses on multiple procedures. During the same operative episode, multiple procedures are coded if, and there's always an if. Coding always has an if, all right? So, first up, guideline A. Guideline A. If the same root operation is performed on different body parts as defined by a distinct value of that body part character, you can code it separately. So let's pause because I know you're thinking, okay, that sounded pretty confusing. So let's rewind. Multiple procedures are what we're talking about. And if the same root operation is performed on different body parts as defined by a distinct character value, that's just a number, guys, one of the numbers or letters of ICD-10 PCS, you can code it separately. Example, if the patient has an excision of the liver and the pancreas, you can code them separately. Why? The liver has a distinct character value. The pancreas has a distinct character value. Next guideline, if the same root operation is repeated in multiple body parts, and those body parts are separate and distinct body part values classified to one ICD-10 PCS code, you can code it separately. Example, excision of the sartorius muscle or the sartorius muscle and excision of the gracialis muscle are both classified in the upper leg muscle body part value. But if the doctor is doing the procedure on both of those body part values, you can code them separately. Next up, guideline C, B3.2C. Multiple root operations with distinct objectives performed on the same body part. Multiple root operations, multiple meaning more than one, root operations with distinct objectives on the same body part. So let's say the patient has a destruction of a lesion on the duodenum and a bypass on the duodenum. Those are two distinct body part values, but we had multiple procedures performed on the same site. All right. Last guideline here is if the intended root operation is attempted using one approach, but is then converted to a different approach, you can code both. So let's say the doctor is setting out to do a laparoscopic appendectomy, and he realizes he can't do it laparoscopically. He converts it to an open appendectomy. You're going to code both procedures. One is going to be coded as an inspection. The other one is going to be coded as a resection. All right. Next up, guideline B3.3 speaks about discontinued procedures. If the intended procedure is discontinued or not otherwise completed, you're going to code the procedure to whatever root operation is performed. However, if the procedure is discontinued before any other root operation can be performed, you're going to code to the root operation inspection of that body part or anatomical region that is being inspected. All right, next up, we're going to go on to biopsy procedures, starting with Guideline B34A, okay? Biopsy procedures are coded using the root operations, excision, extraction, or drainage, and the qualifier diagnostic. Guideline B34B. This is when you have a diagnostic procedure such as excision, extraction, or drainage that is then followed by a more definitive procedure at the same site. You're going to code both. All right. Okay. So let's say the patient had a biopsy of the breast, diagnostic, followed by a partial mastectomy at the same site. What you're going to do is code both. Okay, next up, B3.5, which are procedures on overlapping body layers. If the root operation, excision, repair, or inspection are performed on overlapping layers of the musculoskeletal system, we're going to code the body part that specifies the deepest layer. So when you're reading the operative report for this type of procedure, you do have to decide, okay, what is the deepest layer anatomically? Next up, bypass procedures. One thing I want you to know about bypass procedures is that we have coronary bypass procedures and we have non-coronary bypass procedures. Guideline B3.6A is speaking to non-coronary bypass procedures. So for non-coronary bypass procedures, they are coded by identifying the body part bypassed from, represented by the fourth character, and the body part bypassed to, represented by the seventh character. For example, if the patient has a bypass from the stomach to the jejunum, stomach is the body part, fourth character, body part bypassed from, and the jejunum is the seventh character, the body part that is bypassed to. All right, next up, still talking about bypass procedures, we're going to get into our coronary artery bypass procedures. Coronary artery bypass procedures are actually coded differently than other bypass procedures. So different than what I just spoke about regarding non-coronary bypass procedures. With coronary bypass procedures, rather than identifying the body part bypassed from, the body part identifies the number of coronary artery bypass to, and then the qualifier specifies the vessel bypass from. So it's reversed. So non-coronary from to, coronary to from. Whoa, that was a mouthful. Guideline B36 talks about still bypass procedures, still coronary artery bypass procedures. And here we're looking at situations when multiple coronary arteries are bypassed. If multiple coronary arteries are bypassed, a separate procedure is coded for each coronary artery that uses a different device and or qualifier. All right, On to guideline B3.7, which is control versus more definitive root operations. All right, so the root operation control is defined as stopping or attempting to stop post-procedural or other acute bleeding. Now, if an attempt to stop post-procedural or other acute bleeding is unsuccessful, and in order to stop the bleeding, the provider has to do something else, such as a bypass or a detachment, excision, extraction, reposition, replacement, or resection, the more definitive root operation is coded instead of control. Well, that makes sense. So if they were able to control the bleeding using what's defined as control, then life is good. You code control. But if they have to do a bypass to stop the bleeding, or a detachment to stop the bleeding, or an excision to stop the bleeding, then you're going to code that root operation instead. Next up, guideline B3.8, excision versus resection. All right, so I will tell you, when I first learned ICD-10 PCS, I said, what do you mean excision versus resection? Aren't they the same? Well, one thing that you must remember is ICD-10 PCS has its own definition of terms. Excision and resection both mean taking out a body part. Excision is part of a body part. Excision or resection is all of a body part. So PCS contains specific body parts for an anatomical subdivision of a body part. For example, the lobes of the lungs, or the liver, or parts of the intestine. So if they take out all of that body part, it's resection. If they take out part of that body part, it's excision. All right, next up, excision for graft, which is guideline B3.9. If an autograft is obtained from a different procedure site in order to complete the objective of the procedure, you can code that autograft separately. And just to remember, autograft is self, auto, like driving your automobile. All right, next up, we have guidelines for fusion procedures of the spine. We got 3 different guidelines here. So first, B3.10a, the body part coded for a spinal vertebral joint or joints that are rendered immobile by a spinal fusion procedure is going to be classified by the level of the spine. Go back to your anatomy if you forgot what we mean by level of the spine. This is important because there are distinct body part values for single vertebral joint and for multiple vertebral joints at each spinal level. Guideline B3.10b, if multiple vertebral joints are fused, a separate procedure is coded for each vertebral joint that uses, watch this, a different device and or qualifier. And you'll know that when you get to the table to build your code. All right, next up, we're still talking about fusions of the spine here with guideline B3.10c. We're going to look at devices and materials that are often used on a vertebral joint to render the joint immobile. When combination of devices are used on the same vertebral joint, the device value is coded as such. First, if an inter-body fusion device is used alone or with other material, such as a bone graft, we're going to code this to an interior fusion device. If the bone graft is the only device that is used, we're going to code this as a non-autologous tissue substitute or an autologous tissue substitute. If there is a mixture of autologous and non-autologous bone graft that is used to render the joint immobile, we're going to code the procedure with a device value of autologous tissue substitute. Now, I know some of you are thinking, how am I going to remember all these guidelines? Keep reading them. You can keep replaying this video. All right, next up, inspection procedures. And we have 3 guidelines here, starting with B311. Inspection of a body part performed in order to achieve the objective of the procedure is not coded separately. So for example, let's say that the doctor does a fiber optic bronchoscopy. In order to irrigate the bronchus, we're only going to code the irrigation of the bronchus. The bronchoscopy is then identified by the approach character. Guideline B311B. If multiple tubular body parts are inspected, the most distal body part is coded. So the distal, that's the furthest from the starting point of the inspection. If multiple non-tubular body parts in a region are inspected, we are going to select the body part that specifies the entire area inspected. Guideline B311C. When an inspection procedure and another procedure are performed on the same body part during the same episode, if the inspection procedure is performed using a different approach than the other procedure, then you can code the inspection procedure separately. Again, in order to be able to apply these guidelines, you essentially have to memorize them. That's really the bottom line. All right, next up, guidelines B312. All right, so here we're looking at occlusion versus restriction for vessel embolization procedures. So if the objective, and this is going to be in the documentation, if the objective of an embolization procedure is to completely close the vessel, the root operation of occlusion is used. However, if the objective of an embolization procedure is to narrow the lumen of a vessel, the root operation restriction is used. So you have to be able to identify the objective of the procedure as referenced by the documentation. All right, guideline B313. We're going to look at release procedures. So in the root operation release, the body part value is the body part that is being freed. It's being set free, and not the tissue that is being manipulated or cut to free the body part. So it is the body part that is being freed. So when you code a release, what is the body part that is being freed? All right, guideline B3.14 speaks to release versus division. If the sole objective of a procedure is freeing a body part without cutting the body part, the root operation is released. If the sole objective of the procedure is to separate or transect a body part, the root operation is going to be division. So you as the coding specialist, you must identify via the documentation what is the objective of the procedure. All right, next up, guideline B3.15, reposition for fracture treatment. Reduction of a displaced fracture is coded to the root operation reposition, and the application of a cast or a splint in conjunction with the reposition is not coded separately. So this is a displaced fracture. However, if the doctor treats a non-displaced fracture, it's going to be coded to the procedure that was performed. Next up, let's see, did I skip something? I think I did. B3.16. B3.16, transplantation versus administration. Transplantation is defined as putting in a mature and functioning living body part taken from another individual or animal. That's transplantation. Putting in autologous or non-autologous cells is coded to the administration section. Very, very important. So, for example, if the doctor does a heart or a lung transplant, that's coded as transplantation. But if it's a bone marrow, it's coded as administration. All right, next up, we're going to go on to guideline B3.17. I'm on the wrong slide. B3.17. All right, now we have the correct slide here. So the root operation transfer contains qualifiers that can be used to specify when a transfer flap is composed of more than one tissue layer, such as with a musculocutaneous flap. When you have procedures involving the transfer of multiple tissue layers, including skin, subcutaneous tissue, fascia, muscle, the procedure is coded to the body part value that describes the deepest layer in the flap. And then the qualifier can be used to describe the other tissue layers in the transfer flap. All right, so now we're going to go on to body part guidelines. So first up is guideline B3.1a. B3.1a. And actually, let's just correct this right here. This should actually be B4.1a. So B4.1a is relating to situations when a procedure is performed on a portion of a body part that doesn't have its own body part value. An example could be the alveolar process. The alveolar process does not have its own body part value, and so it's coded to mandible. Now, you're probably thinking, how did you know that? In your ICD-10 PCS manual, you have a body part key. That's an appendix. That's a very helpful resource. You can also look up alveolar process in the index, and it will tell you to see mandible as well. All right, next up, B4.1b is related to the prefix peri. Now, here is a medical term that you learned in medical terminology, and it is the same in PCS. Woohoo! So the prefix peri if it is combined with a body part to identify the site of the procedure, and the site of the procedure is not further specified, then the procedure is coded to the body part named. For example, perirenal is coded to kidney. Next up, B4, 1C, which is about a continuous section. If a procedure is performed on a continuous section of a tubular body part, code the body part value corresponding to the furthest anatomical site from the point of entry. Don't code where you start off, you code where you end up. B4-2, branches of body parts. Where a specific branch of a body part does not have its own body part value, as described by the PCS system, the body part is going to be coded to the closest proximal branch that has a specific body part. And you're going to let the index and the body part tables guide your decision-making process. B4-3 is about bilateral body part values. And in ICD-10 PCS, bilateral body part values are available for a limited number of body parts. If the identical procedure is performed on contralateral body parts, contra meaning opposite sides, and a bilateral body part value exists for that body part, then you're going to use one code. However, if no bilateral body part value exists, each procedure is coded separately using the appropriate body part value. So it either does or it doesn't. All right. Next up, a familiar friend, the coronary arteries. So guideline B4.4. The coronary arteries are classified as a single body part value that is further specified by the number of arteries treated. One procedure code specifying multiple arteries is used when the same procedure is performed, including the same device and qualifier values. Next up, B4-5, tendons, ligaments, bursa, fascia, oh my, that are near a joint. Procedures performed on the tendons, ligaments, bursa, and fascia supporting a joint are coded to the body part in the respective body system that is the focus of the procedure or the treatment. Procedures that are performed on the joint structures themselves are coded to the body part in the joint body systems. We're almost done, guys. B4-6 is related to skin, subcutaneous tissue, and fascia overlying a joint. If the procedure is performed on the skin, subcutaneous tissue, or fascia overlying a joint, the procedure is coded to the following body parts: shoulder, upper arm; elbow, lower arm; wrist, lower arm; hip, upper leg; knee, lower leg; ankle is coded to foot. Next up, B4-7, fingers and toes. If a body system does not contain separate body part values for fingers procedures performed on the fingers, we're going to code it to the hand. If the body system does not contain separate body part values for toes, toes are, of course, coded to, you guessed it, the foot. All right, B4-8. This is about the upper and lower intestinal tract. I should say, in the gastrointestinal body system, the general body part values, upper intestinal tract and lower intestinal tract, are provided as an option for the root operations change, inspection, removal, and revision. Upper intestinal tract is going to include the esophagus through the duodenum. The lower intestinal tract is the jejunum through the rectum and the anus. All right, guys, next up, we're going to go to our approach guidelines. Guideline B5-2, procedures performed using the open approach with percutaneous endoscopic assistance are coded to open. It's all about what's documented that guides your selection. B5-3A, procedures performed within an orifice on structures that are visible without the aid of any instrumentation are coded to external approach. B5-3B, procedures performed indirectly by the application of external force through intervening body layers are coded as the approach external. B5.4, procedures performed percutaneously via a device placed for the procedure are coded to the approach of percutaneous. All right, lastly, for this particular section, we're going to look at our device guidelines. B6-1A, a device is coded only if a device remains after the procedure is completed. If no device remains, the device value, no device, is coded. In limited root operation, the classification, and notice I said limited. In limited root operation, the classification provides the qualifier values for temporary and intraoperative for specific procedures involving clinically significant devices where the purpose of the device is to be utilized for a brief duration during the procedure or a current inpatient stay. Of note, if a device that is intended to remain after the procedure is completed before removal, before the end of the operative episode for which it was inserted, both the insertion and the removal of the device should be coded. B6-1B, materials such as sutures, ligatures, radiological markers, and temporary post-op wound drains are considered integral to the performance of the procedure, and they're not coded as devices. So that means you need to become familiar with materials such as sutures, ligatures, and radiological markers and temporary post-op drains. You must Google every word in the operative report that you don't know the meaning. Guideline B6.1C, procedures performed on a device only and not on a body part are specified in the root operations of change, irrigation, removal, and revision are all going to be coded to the procedure that was performed. And lastly, for this particular section, drainage device. A separate procedure to put in a drainage device is coded to the root operation drainage with a device value of drainage device. All right, enough of that medical and surgical section. On to the very small section of obstetrics, starting with guideline C1, which are the products of conception. Procedures that are performed on the products of conception are coded to the Obstetrics Section. Procedures performed on the pregnant female other than the products of conception are coded to the appropriate root operation in the medical and surgical section. C2, procedures performed following a delivery or an abortion for curettage of the endometrium or evacuation of a retained product of conception are all coded to the Obstetrics Section to the root operation of extraction and the body part value of products of conception retained. Other times, when there is a diagnostic or therapeutic dilation and curettage, other times other than the postpartum or post-abortion period are going to be coded to the medical and surgical section to the root operation of extraction and the body part of endometrium. All right, next up, we're going to go to our guidelines for new technology. Section X codes are actually standalone codes. They are not supplemental codes. Section X codes reflect the specific procedure described in the code title and do not require any additional codes from other sections. When a Section X code contains a code title which describes a new specific technology procedure, only that X code is reported for that procedure. There is no need to report a broader non-specific code from any other sections of ICD-10 PCS. All right, lastly, selection of the principal procedure. So there are guidelines for selection of the principal procedure, and this is directly in relation to the principal diagnoses. So principal diagnoses is when we're talking about ICD-10 CM, which is not what we're talking about here, but the principal procedure and the principal diagnoses have a relationship. So we have 4 guidelines here that are notable. First, procedures performed for definitive treatment of both a principal diagnosis, that's the one that would be listed first, and the secondary diagnosis. In this case, we're going to sequence the procedure performed for definitive treatment, which is most closely related to the principal diagnoses. Let's do a visual. You got a principal diagnosis and you got a secondary diagnosis, and the procedure is performed for definitive treatment. You're going to code the procedure related to the principal diagnosis first. All right, when you have a principal procedure performed for definitive treatment and diagnostic procedures performed for both the principal and the secondary diagnoses, you are going to sequence the procedure performed for definitive treatment most related to the principal diagnosis. So principal means you go first. That's basically what it means, okay? Guideline 3, diagnostic procedure was performed for the principal procedure, and a procedure is performed for definitive treatment of a secondary diagnosis. This is all about, guys, which procedure goes first. Sequence the diagnostic procedure as the principal procedure, since the procedure most related to the principal diagnosis takes precedence. And lastly, no procedures performed that are related to the principal diagnoses. Procedures performed for a definitive treatment and diagnostic procedures are performed for the secondary diagnoses. In this case, sequence procedure performed for definitive treatment of the secondary diagnoses as the principal procedure, since there are no procedures related to the principal diagnoses. All right, guys, this has been Dr. Campbell, and I have brought to you our 2019 ICD-10 PCS Guidelines. Much success to you all.